Okay, everyone, this is just going to be a really quick neuro review. This is just in my notes app. I'm just going to draw really quick, point out some quick topics, but you're going to see a bunch of like my scrolls and stuff. So the first thing I want to cover is lateral gaze, and what this is, let me scroll up to the cross sections. So this is going to be the connection between let's do red. This is going to be the connection between cranial nerve 3, your oculomotor, and cranial nerve 6, the abducens. And so these two are connected via the medial longitudinal fasciculus, the MLF. And so the MILF here is going to play an important role when you want to look to the right or to the left. And so I'll quickly point out here, so our oculomotor nucleus is going to be way at the top because cranial nerve 3 is up here, and I'll point this out later, but oculomotor nucleus right here. And so the MLF is going to be something we can follow down. We can follow down all the way through, blah, 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 until it starts to get close to the abducens nucleus here. And so you can see that's going to run right next to it. So that's going to connect the abducens and the oculomotor. And so the importance of this is we have two eyes, right? These are the pupils, and then you've got all your muscles. I hope that's apparent what that is, but so say you want to look this direction. With this eye, you're going to send a signal to the lateral rectus muscle to pull it, and that's going to move, that's going to move your pupil that way because it's going to move your eye that way. And so this is our lateral rectus, which abducts the eye, and so that's our abducens, so cranial nerve 6. But if we want to move this pupil the same direction, that way, we're going to need to use this muscle, which is not our lateral rectus, and therefore not our abducens nerve. It's going to be our medial rectus, which is innervated by cranial nerve 3, oculomotor. And so we'll use the oculomotor to activate the medial rectus to pull the eye that way, and that way they go the same direction. And so we want to have some signal that when we activate cranial nerve 6, it sends a signal to cranial nerve 3 to also be activated. And that's going to be this pathway right here. We activate cranial nerve 6, sends a signal up via the MILF to cranial nerve 3. And so that's how that's going to work. And that's the important part. So now let's talk about how you'll probably see it, which is going to be a lesion or something messed up with it. So say you have your eyes, you want to look the same way, you look this way, but that pupil doesn't respond on the other side. This one just stays right there. So what could that be? Well, we can activate the abducens nerve on this side, therefore the lesion is not in the abducens nerve because that's fine. And it'll probably say like this eye can look like that way still, so the abducens are still fine, but we're not able to look that same way. And so what happens is if you get a lesion like right here or something on the MLF, then when you activate cranial nerve 6, the signal will try to go through, but it's lesion, so it can't get through. And so it's not going to simultaneously activate cranial nerve 3, so they're not going to be looking the same direction. And that's a really important topic. I would make sure you understand that well. I would say there's like guaranteed to be at least one question about it. Any questions, let me know. The next topic I want to look at, let's skip down to this one. So this is what I use. It's a quick drawing. So when thinking about the brainstem and you want to think about what cranial nerves nuclei are where, this is my quick drawing of the brainstem. I just do like boom. And so this is our big one. This is our medulla. This is the pons. This is the midbrain. And so if you haven't noticed, the cranial nerves are pretty much named for the direction that they move. It's more external, but they tend to follow the same pattern in here. So I just quickly draw this, and then I go 3 and 4 are up in the midbrain. We have 5 nope, not right there. It's going to be the whole thing. So we have 5 travels everywhere. And then we have 6 and 7 in the pons. 8 is kind of on the border, so you should draw it like that. And then we have 9 through 12 down here. And so this can just give you, this is just like a quick drawing that I do, so I'll just be like boom, 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 3, 4, 5, 6, 7, 8, 9 plus. And so that can just help you if you're looking at a cross section, you identify it's the medulla, you know you can automatically rule out anything that's up here. Or vice versa, if it's midbrain, you can rule out everything that's not those. And that can help you with a lot of questions, because also with like blood supply, if you have blood supply, you can identify that the blood is supplying the pons, then you're gonna be like, okay, we're probably gonna lose function of cranial nerves 6 and 7. So that's my quick drawing, hope that helps. Let's cross those off. Next, let's look at the facial nerve lesions. So let me go to my drawing, or this was from Dr. Eel's slide. And so this is something else I think there will probably be a question on. So this is the difference in facial nerve if you have an upper motor neuron lesion or a lower motor neuron lesion. And so I don't know if you can understand this, but basically we have our happy little face here with eyebrows. The eyebrows are going to be the important part, I'm sure, in the question. And so we have our facial nerve nuclei for each side. And so what they're going to do, what this is showing, is we're going to have the nerve comes down and goes to the face. Comes down and goes to the face. But it actually has 2 components. And so we start higher up in the brain. And so higher up in the brain, we're going to send a signal down here. And signals to the opposite side. And so there's actually 2 components in the facial nerve. And so this would be the same thing. We'll go one to the top one, and then both on the other side. And so that's what's drawn here. And so basically what it's saying is, in this facial nucleus, you're going to have components that run out and go to the bottom of the face. You're also going to have components that run out and go to the top of the face. The interesting part is that the bottom of the face, you can see that only has one thing coming from it. So that's only bilateral innervation. The upper motor, or the upper one, this is not the upper motor neuron. These are the upper motor, these are lower motor. So the one that goes to the top of the face is innervated ipsilaterally and contralaterally. And so what this is saying is, if you get a lesion like down here, so these are separated, but this is going to be on one nerve. These are just different components. And so if you get a lesion here that wipes out the lower motor neuron past the nucleus, then you're going to get complete paralysis of that side of the face, because just nothing can get out the facial nerve. And so it's interesting, that's what you would expect, right? If you have a lesion on the facial nerve, you get paralysis of the face. That's Bell's palsy, what we learn, kind of Bell's palsy. And so the interesting part is no matter where the lesion is, lower motor neuron or upper motor neuron, you're going to lose this lower component. But since the upper face is innervated by the ipsilateral and contralateral side, then if we have an upper motor neuron lesion, that's only going to eliminate this one. We still have the other side giving innervation to that. And so we're going to retain function on the top. And so what the question will probably ask is, the patient has some paralysis on their lower left side of their face, but they can still raise their eyebrows. And that should indicate to you that this is going to be an upper motor neuron lesion. And so, again, if you're paralyzed only on the lower half, right here, then that's upper motor neuron lesion. If you're paralyzed on the entire half of your face, then that's lower motor neuron. Again, hope that makes sense. Next, let's look at blood supply and pathology. I think this is going to be a really big topic, so all of these slides, this might seem a little overwhelming. There's so much stuff here, how to remember all this, and so I've been trying to think of a way to organize it, and so I'll quickly go through that. Hopefully this helps a little, but I want to first point out I think there's probably no way they ask about locked-in syndrome just because it's so easy and everyone could probably get that. You only move your eyes from damage in the pons. We'll still look at it, but I would spend your time on these other ones. And then you really want to focus on the differences. And so you can memorize the key phrases. I'm going to kind of come up with a way where you don't really need to do that as much, but basically you see Horner's, you think, okay, it's these two. What's the difference? That all looks the same. That all looks the same. The difference is going to be the cranial nerves they were in. And so, okay, so my drawing, this is the circle of Willis. I don't know if you remember that from anatomy, but so let's see, we've got, just to quickly run through it if you don't remember, we have our pica here, we have our vertebral arteries here, we have our anterior spinal that goes into our basilar, we have our ACAs, we have our superior cerebellar, posterior cerebral, and then the circle of Willis up here. But we're not looking at that because, like we learned in anatomy, if you have a lesion on one part, so if I had a lesion right here, we still get circulation that can access everything. So those aren't as severe. And so basically I tried to break it down like this. So the way I think, first we have, let's do a quick drawing here. So we have our midbrain, 3 and 4, pons, we have, 5 here, pons we have 6, 7, 8, 9 plus, okay. And so of these disorders, we're gonna have 1 in the midbrain, we're gonna have 2 in the pons, and 2 in the medulla. And so when you break it down like this, 1 in the midbrain, 2 in the pons, 2 in the medulla, and then we're also kind of just gonna be like lesions at all the major spots. I don't know if this is going to make sense to other people, but this is how I think about it. So lesions at the major spots, so like pica, ACA, basilar, vertebral, and anterior spinal, and then posterior cerebellar. And so midbrain, we know we have 1 in the midbrain. Which one would you think that would be? That's probably going to be the one that's highest up because the midbrain is highest up. And so that's going to be our posterior cerebral is the way I think of that. And so when you think about this, I haven't really thought, so when you think about this, midbrain, you're going to think, what disorder is that? It's going to be the one that has midbrain in it. The ones in the pons, they have pons in it. The ones in the medulla, they have medullary in it. And so if you identify that it's in the midbrain, it's going to be the one in the midbrain. So whatever, you don't got to remember the names, just remember where it's at. And so we're in the midbrain. What cranial nerves do we have here? We have 3 and 4. So we look at this. I put down that cranial nerve 3 is going to be lost, and we're going to have face and body weak. So let's go up to that. This is this one. And so, yeah. I don't know. This is my quick drawing. I hope this helps, but it's basically just, you have 1 midbrain that's going to lose cranial nerve 3 because that's at the region of cranial nerve 3. And so that's kind of be why you have like this big pupil because you lost oculomotor. You're going to have the down and out. And so you're going to see cranial nerve lesion function loss. You're also going to have the face and body weak just because if you remember, when we look at the midbrain, what do you have up here? You have your oculomotor nucleus, you have some motor function, and then some other stuff in here. And so that just makes sense to me that we're going to lose oculomotor and motor because those are the 2 big things in the midbrain. And so that's that one. The 2 in the pons, again, we have locked-in syndrome, which is basically basilar, the whole main one right here. If you lose that, you're going to be completely paralyzed except for your eyeballs. So that's that. Then we also have lateral pons. And so we're in the pons. Let's see, we have 6 and 7. So I put cranial nerve 7. Let's see, lateral pons is right here, lateral pontine syndrome. And so we're in the pons. We think about what we're losing. Sorry, I'm trying to think of this as I go. Cranial nerve 7. And so what I put here, both of these 2, the ACA and PICA, they're going to be the 2 that have Horner's, and you're also going to lose, in common, you're going to lose cranial nerve 5, spinocerebellar, ALS. So you're going to have basically like a ton of loss. So ACA and PICA, those are the ones that are going to look the same. So you have all this whole weird body, opposite things. You have Horner syndrome. And if you are trying to remember like which side it's on, just think, if you have the lesion like up here in your brain, pain and temp, well, that's at the face. Pain and temp of the body, that comes in, crosses immediately. Let's do it the other side. That comes in, crosses immediately, and runs up. So that's already crossed. So you're going to lose that of the opposite side. Ataxia, that's going to be motor loss. So that comes down and crosses. And so that's going to be, that's spinocerebellar. So I'm getting confused. So spinocerebellar, that one doesn't cross. So you have your brain or your cerebellum comes down, that's always on the same side. So that's why it's going to be ipsilateral. And so you can kind of just think about, if I have a lesion there, what am I going to lose? I know spinocerebellar, or here, let me draw this. So these ones, your spinothalamic, spinocerebellar, we know those run all the way up. So we know we're going to wipe them out. And then that's just thinking about spinocerebellar is going to be on the same side. ALS is going to come down and cross, so that's going to be the opposite side. And then face, pain, trigem, that doesn't cross. So that's going to be the same side for pain on the face. Let's see. And then, cranial nerve 7, because we're in the pons, so you're going to get facial droop. You could also think, like, if you got confused, you could at least be like, it's 6 or 7. 6 is abducens. We don't really see anything with that, but you guess it's either 6 or 7. 7 is facial droop. If you see facial droop, you know that that's got to be cranial nerve 7. You know that's got to be the pons. You know it's not locked in syndrome, therefore it's got to be the lateral pons syndrome. Sorry if this is not making any sense. And then the 2 medullary ones, I like to think pica is like a special one, so it gets its own, and then these can kind of be the either one, the vertebral or the anterior spinal. And so when we get to the midbrain, we have 9, 10, 11, 12. And so the difference in these, lateral medullary is going to be 9 and 10, and then medial medullary is going to be 12. And it's also going to do these other stuff. And so when we look at, let's see where these are. These are at the top. So thinking about what's medial and lateral, the lateral one for me is a little more confusing because there's a bunch of like random crap, like sympathetic pain. I don't know. That's just like confusing, hard to remember. So that's going to be, for me, the other one that you remember. And then medial medullary, that's going to be a little easier for me to remember. So first, I think I'm in the medulla. What's in the medulla? So we have our medullary pyramids, obviously. So we're going to lose motor to some way. And that's going to be, it hasn't hit the decussation yet because we're still in the brainstem. So it's going to cross below this. And so it's going to be motor loss on the opposite side. We have our medial lemniscus. So we're going to lose, so this is already crossed. So as we run down, that's also going to be touch sensation lost on the opposite side. Run up here, there's some other crap. And then we've got cranial nerve 12, which is up here. And so that's why you're going to get licking your side. And so I just think, I picture the cross-section. Maybe there's going to be another picture with this cross-section so you can reference that. But I just think you can remember in the medulla, you're going to have your pyramids, you're going to have your medial lemniscus. And then maybe you can remember the hypoglossal is going to be here. It's just remember 12 is going to be the lowest. So that's going to be there. Lick your lesion, it's going to be the side of the lesion. And then you can guess, like, these are going to cross as you go down. And so that's why it's going to be contralateral. And that's just going to be the, I like to remember that that's the medial one because, I mean, anterior spinal is in the middle. Pica sticks out sideways. So the pica is going to be the lateral one. If you want to look at this one specifically, they're going to be pretty different, but thinking about, we're in the medulla, we lose lateral stuff, what are we going to lose? So we have these, we have our lateral things. So we know our spinocerebellar tract runs laterally. Even in the spinal cord, it runs all the way out here. As we get up, it's always really lateral. And so if we lose lateral, we're probably going to lose spinocerebellar, which is going to be the same side affected. The ALS up in the brainstem, it's going to be really lateral too. So we're probably going to lose that. Looks like we lose cranial nerve 5, so we're going to lose pain to the face. And then you'll get Horner syndrome. And so this is going to be 9 and 10. So let's see, we go up here. Lateral, yeah. So 9 and 10. So we have 12 here. We're going to have like 9 and 10 up here somewhere. And so that's why you're going to lose like hoarseness, dysphagia, because you're affecting 9 and 10. I know that was kind of all over the place. Hopefully that helped a little bit. Again, let me know if you have questions about that. Cross sections, I'll look at last. Let's look at the receptor stuff really quick. I'm not going to spend too much time on this. This is my tables and crap that I made. If you like them, you can take a picture or whatever, copy them. But basically, somatosensory, I just group it like this. We're going to have 2 rapid, 2 slow. And among the rapid, we're going to have a big and a small. Among the slow, we're going to have a big and a small. And these are like adapting field size. You can read what that says. And then, so I don't know. I just plan to like memorize this table to some extent. Going down, remember you want to remember C is not myelinated, pain, that's the oldest one, so it doesn't have myelin yet. A alpha, big motor, it's and then other sensations are kind of in between. What else? We have DCML. This is just that. Yeah, I'm not going to talk about that. You can look at it. And then here's just a table of all that stuff if you want to memorize it. This stuff, honestly, I'm just going to do a lot of, like, memorize these tables. This is my condensed notes. This is everything I thought was important that I couldn't reason through, so take with that as you will. And then cross-sections. I'm just going to super quickly go through the cross-sections, things that I think are really important. So, obviously you want to be able to identify all of your major tracks. So I'm going to super quickly run through that. So you have, let's see, let me get my laser. All right. So you're going to have medullary pyramids run up. They're going to decussate, be here. They're going to cross medullary pyramids, medullary pyramids, medullary pyramids. Run up through the pons is corticospinal fibers, corticospinal fibers, corticospinal fibers, corticospinal fibers. And then up here, they're going to be the pes or the crus. Up here, they're going to be pes or the crus. So those are just going to be pretty much in the same spot all the way up. Next, we have our spinocerebellar. So again, that's running really laterally. Move up, running really laterally. Up here, they start to go up in the cerebellar peduncles to the cerebellum. We're still going to have a little bit here. Still a little bit here, still a little bit here. Again, starting to give off into the peduncles a little bit. But basically, the main point is it's just going to be like on the side, go off into the peduncles until like eventually we get to the point there's no more. And then the next one, spinothalamic pain. So remember that's right here. It kind of like wraps around the horn whenever we're in the spinal cord. So spinothalamic. Again, it's going to stay in the same spot. That's going to start to migrate over to just be in the side. ALS. And we know that goes all the way up to our thalamus, so that should always be present. ALS. And I want to point out an important relationship that I like to follow. So once we get to the pons, the medial lemniscus, this, the ALS, and you can't really see it yet, but this is going to be the lateral lemniscus. They form this boomerang-shaped thing. So right here, medial lemniscus is going to be the more medial one, ALS, and then lateral lemniscus will be up here. So we move up a little bit. Let's look at the blank one. So you see medial lemniscus will be the big guy. Probably going to have ALS fibers here, and then lateral lemniscus will be tiny right there. Move up a little bit, same thing. We have medial lemniscus, ALS, lateral lemniscus. Medial lemniscus, ALS, lateral lemniscus. And they continue that up. So here we're going to be medial lemniscus, ALS, lateral lemniscus. And so remember, a lateral lemniscus is carrying fibers to this inferior colliculus right here. And so you're going to see it wrap around like that. And then you just think ALS, ML here. And so once we get to the very top one, we've already given our lateral lemniscus fibers to here. So that's not going to be present anymore. Now we're just going to have our ALS and our medial lemniscus. Okay, those are the main pathways, main things I want to point out. I mean, honestly, you really want to know pretty much everything, just ID-wise, so you don't want to miss any first-order questions because remember the practical is half your grade, the computer exam is half your grade, so practical is easy points. Make sure you get those easy points if you simply memorize it, but there's Ankis and stuff like that. So these things are that internal arcuate fibers are crossing of the nuclei to the medial meniscus. Oh, I didn't go through that pathway. Let's go through that really quick. So our fasciculus, cuneatus, and gracilis will come up here and go into the nuclei. They're gonna, as we move up, they're gonna start crossing via internal arcuate fibers to the medial lemniscus, and then eventually get our medial lemniscus. And you can see the little face here. She didn't have the head, so I drew heads, but it's really important to think. So we have our gracilis, which is going to be our lower body, our cuneatus, which is going to be our upper body. So right now, gracilis is here, cuneatus is here. So feet, head. But then when we get here, we're going to have head, feet. So let me do feet, head, feet. And so what's going to happen is we're going to rotate as we go on. So it's going to kind of be like whoosh, if that makes sense. And so this will be whoosh. And so that's how you can remember. And then I also just remember heads like higher up, feet are lower down towards your pyramids, whatever. We run up, it's going to be the same thing. Medial meniscus, and then we start to get to the medial meniscus as we were looking at later. Okay, yeah. Really quickly, know your nucleus ambiguous is around here. I would be able to identify the MLF in every segment. That's going to be important, I'm sure. The cerebellar peduncles, inferior, middle, superior, solitary nucleus, and solitary tract. Make sure you remember the nucleus. Here you can see it. The nucleus is the outside, the tract is the middle. So I think the tract is like the egg yolk, and then the nucleus is the egg white, which is backwards. So I don't know if that confuses you. Same things there. Pretty much same things there. Make sure you know abducens. We have our facial motor, which sends out its signal, wraps around the abducens. And so if you're looking at it externally, you're going to see the facial nerve components, but it's going to be the abducens nucleus. There'll probably be a question on that. Let's see. Yeah, I mean, again, pretty much want to know all of this. I'm just trying to point out major stuff. Here your DILF is coming up to your MILF. They want to talk. Yeah, make sure you remember the manatee is inferior. She says jellyfish. I don't know. I just think the one that is not a manatee is superior. You should also be able to see your lateral lemniscus going to the inferior colliculus. Let's see. And yeah, so right here, we talked about that boomerang. So right here we get the brachium of the inferior colliculus. I know this is the superior colliculus, but it's the tract running from this one here. So this goes into that and then runs up via here. But yeah, one last thing, the relationship here. So we have the 3 V's. So I drew it like this. We have our MLF. Inside that we have our cranial nerve 3 nucleus, and then we have Ehringer-Westphal. So dark is our MLF because that's been dark everywhere, and it's tracks. Oculomotor nucleus is going to be white right here, and then we have the Ehringer-Westphal right here. It's a little bit darker. And so remember, dark is going to be tracks. So the stain that's used in all of these is a myelin stain, and so it's going to turn tracks purple, nucleus will not be stained, and they'll be white. I hope that helps. This is just like a bunch of random stuff. Send me messages or anything if I can be of more help. But yeah, good luck everyone on the exam.